Senior Services in Forsyth County, North Carolina presents Dementia Scales and Stages. What's next? This presentation summarizes the scales and stages that many caregivers encounter on the journey of dementia with their loved one. The presentation is not meant to cover every scale utilized by medical professionals, but rather help caregivers to understand how medical professionals use scales and how that information can correlate to provide the best care for the loved one living with dementia. This presentation has been pre-recorded, and information about how to find help is included at the end of the presentation. Scales are used by medical professionals to measure the severity and the progression of the disease. Since each case of dementia is unique to the person, measuring its progression can help medical professionals provide interventions that are needed to ensure the highest quality of life. The scales help define the stages that caregivers and persons living with the disease may go through. They can help caregivers understand what to prepare for and help persons living with the disease understand what could happen to them. So let's start our conversation by talking about scales. Not the kind that we try to avoid when we go see our primary medical provider, but the kind that medical professionals use to measure the severity of the disease. Not to get too sciencey, but scales are assessments, and the purpose is to increase the precision of the diagnosis by reducing bias and subjectivity and increasing objectivity. A dementia assessment is used when a clinician wants to make sure that what is being described is not normal age-related cognitive decline. Primarily used by healthcare professionals such as neurologists, geriatric psychiatrists, neuropsychologists, geriatricians, and gerontologists, a scale assessment is a way to measure objectively what is happening in a person's brain. A good scale measures up to other people's use and opinions. It works the same for everyone. A good scale produces the same information reliably, either when used repeatedly with other people or when two clinicians give the same assessment to one person. A good scale is put together well and is just the right length without being overwhelming, exhausting, or embarrassing to the patient. If you see that the assessment being given to your loved one is too taxing, talk to your loved one's medical provider about other assessment options. On the screen are multiple types of dementia scales that medical professionals use. We're going to talk briefly about each one. A Global Deterioration Scale, or GDS, is used to assess and stage the progression of the disease. It is a 7-point scale, with some points having various levels, so you may hear a medical professional refer to stage 6B or 7E. A functional assessment staging tool, or a FAST, assesses and stages the progression of dementia, particularly Alzheimer's disease. This one primarily measures functional abilities and identifies specific challenges. The Allen Cognitive Levels assesses different levels of cognitive functioning, ranging from severe to mental impairment. The Clinical Dementia Rating assesses and stages dementia, particularly Alzheimer's disease, and tracks its progression. It involves both the patient and the caregiver and evaluates 6 domains, which are memory, orientation, judgment or problem solving, community affairs, home and hobbies, and personal care. The Clock Drawing Test assesses executive function, visual spatial skills, and attention. It's used to screen for dementia, especially mild to moderate cases, and it can be used to assess for other cognitive impairments and neurological conditions. Continuing with dementia scales, let's talk about the Mini Mental State Examination, or the MMSE. It's a brief test that assesses function in older adults and those suspected of having cognitive impairment. It tests orientation, concentration, attention, verbal memory, naming, and visual spatial skills. It can be used to track changes over time. The Montreal Cognitive Assessment, also known as the MoCA, is a brief screening tool to assess and detect mild cognitive impairment. It also tests attention, working memory, language and executive functions, visuospatial skills, concentration, language, orientation to time and place, and abstraction. Addenbrook's cognitive examination, or the ACER, is used to test 5 cognitive domains: attention or orientation, memory, verbal fluency, language, and visual spatial abilities. So why do medical professionals and caregivers want dementia scaled? Scaling dementia focuses on the changes listed on the screen. Cognition is the key change observed in a person living with dementia, and diagnosing dementia is determinant upon cognitive impairment as well as behavior and impairment of function. Function refers to the abilities to carry out activities of daily living, which is a direct consideration at the point of diagnosis of dementia. It is also important for assessing change and planning care interventions. Behavior changes seen in dementia are important for prescribing medication and intervention recommendations for the person living with dementia, as well as addressing caregiver stress. Quality of life is multidimensional and reflects the person living with dementia's perception of the effect of their illness on their everyday physical and emotional function. There are quality of life evaluations for a person living with dementia and their caregivers, and they usually show very different results. I've seen quality of life assessments where the person living with dementia will state they have a wonderful, carefree life with good health, and the caregiver will report that they have high stress, poor health, and many responsibilities. Depression is common in dementia, both for the person living with dementia and their caregiver, and can be treated effectively with proper diagnosis. Caregiver burden is a major concern, and many community-based programs use some form of a caregiver burden scale to measure effectiveness of that program. If you receive services from a community-based program, please take time to complete those assessment questions. They help improve the services and programs available to others in the community who are living with dementia or caring for someone who does. Dementia severity assessments are designed to assign a level of severity to a patient's condition and are useful to medical professionals as they recommend interventions as well as to research or even service developments. Think about this. Would you want a medical professional to tell you that you have advanced dementia when you really have mild cognitive impairment? No. Using a dementia scale will help your medical provider give you accurate information, not just their opinion or the opinion of their favorite medical professor. And getting accurate information will help you have better quality of life now and help you plan for the future. When we talk about function, we are really talking about the activities of daily living or your ability to perform those. It is important for you to know what these are. As a caregiver, you will be asked many times about these. You will be asked if the person you're caring for can do these on their own or if they need assistance. please remember to accurately describe what your care partner can and cannot do. Try not to give them any extra credit. Programs and services use activities of daily living to help determine who needs help the most. Giving your loved one extra credit for something they really cannot do on their own or without coaching will mean that they score higher than they should. And giving them extra credit means giving you more work to do. So there are instrumental activities of daily living. Those include housekeeping, which is maintaining a clean and organized living environment, phone use, being able to use a phone to call, particularly for emergency services, planning and cooking and serving meals, or also known as food prep, shopping, locating items to purchase, and making change or paying for those items. Transportation means driving or managing transportation systems. Laundry is using a washing machine and a dryer correctly and being able to sort clothing. Money management is paying bills and managing a budget. Medication management is obtaining, sorting, and taking medication as prescribed. Often, people living with dementia will start to falter in these instrumental activities of daily living first. Activities of daily living include feeding, dressing, bathing, toileting, transferring, and continence. Activities of daily living usually start to falter after people lose the ability to do instrumental activities of daily living. We'll talk more about that in just a few minutes, but it's important for you to know these important terms and what they mean. Sometimes the word stages is used interchangeably with the word scales when we talk about dementia. And though we've talked about the Global Deterioration Scale as an assessment tool, many medical providers use it to explain the stage of the disease as well. The scale measures the disease and its progression. A stage is where your loved one is on the journey. The Global Deterioration Scale is most effective if a person has true Alzheimer's disease. The Alzheimer's Association uses stages that we will talk about today. It is perfectly acceptable to ask your care partner's doctor to stage your loved one's progress in the disease instead of using a scale. The Alzheimer's Association uses 3 stages to talk about where a person with dementia is on their journey: mild, moderate, and severe, or early, middle, and or late stages. They're on the screen, all 3 stages, but we're going to split them up and talk about them individually. In the earliest stage of Alzheimer's, changes may begin 20 years or more before an actual diagnosis. Plaques and tangles, shown in the blue shaded areas on your screen, tend to spread through the cortex in a predictable pattern as the disease progresses. The rate of progression varies and is the most difficult part for caregivers. On average, a person lives with Alzheimer's disease 4 to 8 years after diagnosis, but they can live as long as 20 years. The course of the disease depends in part on the age at diagnosis and whether a person has other health conditions called comorbidities. In the milder early stage, a person may function independently. They may still drive, work, and participate in social activities. They may feel like they're having memory lapses, such as forgetting familiar words or the location of everyday objects. They may forget something that they've just read or not be able to retain what they've just read, or they may not be able to recall the name of a person that they just met. Close family and friends may notice changes, and a doctor would be able to identify symptoms using diagnostic tools. In the mild or early stage, instrumental activities of daily living changes include keeping house poorly or just letting things go, struggling to use the phone or the remote control. They may say that their computer is broken. They may have difficulty making change when they're paying with money as when they're shopping. They may get their meds confused or refuse to take them altogether. Typically at this stage, we do not see activity of daily living changes. In the mild to moderate stages, brain regions important in memory and thinking and planning develop more plaques and tangles than were present in the early stages. As a result, individuals develop problems with memory or thinking serious enough to interfere with their work or social life. They may also get confused and have trouble handling money, expressing themselves, and organizing their thoughts. Many people with Alzheimer's are first diagnosed in this stage. As Alzheimer's progresses, individuals may experience changes in personality and behavior and have trouble recognizing friends and family members. Plaques and tangles, demonstrated in the blue on the screen, spread to more areas. People think this is the longest stage, and it can last many years. As the disease progresses, a person will require help with care and more supervision. They may confuse words or get frustrated or angry. They may act in unexpected ways, do things that they've never done before. They may struggle to express their thoughts or perform routine tasks without help. Tasks will need to be simplified and then the person coached through the steps. Caregivers will need respite care. Instrumental activities of daily living changes that we see, in addition to housekeeping, phone or electronic use, an inability to shop, and unable to manage medications, they'll be unable to do laundry. They'll skip steps and recipes, and they'll be unable to react appropriately to unexpected stimuli. Activities of daily living changes appear in this stage. They'll need some help with bathing, dressing, and toileting. Incontinence starts in this stage, and mobility aids may be needed. In advanced Alzheimer's disease, most of the cortex is seriously damaged. The brain shrinks dramatically due to widespread cell death. Individuals lose their ability to communicate, to recognize family and loved ones, and to care for themselves. Symptoms appear severe. A person loses their ability to respond to the environment, to carry on conversations, and to control movement. Significant personality changes may take place, and the person will need significant help with care. The person may not be able to initiate a conversation, but can benefit from listening to music and gentle touch. All instrumental activities of daily living need assistance. Most activities of daily living need help and will eventually become fully dependent. We've talked a lot about stages of Alzheimer's disease, but what about other types of dementia? Other types of dementia, including mixed dementia, do not always follow the same trajectory as Alzheimer's disease does. However, to leave them out of our presentation would be unfair to persons living with dementia and their caregivers who also need to plan for the future. Though the end stages of all dementias look very similar, the path that each takes to get there is unique and is determined by where and how the disease impacts the brain. We cannot also rule out unique individuality. Every person's journey with dementia is unique, and many medical professionals will say if you've seen one case of dementia, you've seen one case of dementia. Let's talk about Lewy body dementia for a moment. Lewy body dementia occurs when protein deposits, called Lewy bodies, accumulate in nerve cells in the areas of the brain responsible for memory, motor control, and thinking. People may initially experience slight memory lapses, mild confusion, and minor attention and problem-solving difficulties. As the disease progresses to the middle stages, symptoms become more pronounced and debilitating. Cognitive impairments may also worsen. Patients may experience memory loss, hallucinations, and motor symptoms like Parkinson's disease, such as tremors, stiffness, and slowed movements. In the advanced stages, individuals with Lewy body disease face significant challenges. They often require 24/7 care and support. They lose the ability to communicate effectively, experience severe cognitive decline, and exhibit pronounced motor impairments. Additionally, behavior changes such as agitation, aggression, and anxiety are common. They may become bedridden as the disease impacts their physical capabilities significantly. Frontotemporal dementia is an umbrella term for a group of conditions, either behavioral variant frontotemporal dementia or primary progressive aphasia, which more affects language. Two different proteins called tau and TDP43 attack the brain's frontal and temporal lobes, which are the sections behind the forehead and the ears. And those sections affect behavior, language, motor function, and causes progressive loss of nerve cells. The most notable symptom in behavioral variant FTD is change in behavior, aggressive behavior or inappropriate language, or trouble forming sentences or speaking coherently, and that's usually progressive aphasia. Memory loss is not usually a symptom until disease progresses. The disease is usually undetectable in its early stage, but in stage 2, subtle behavior changes may begin to emerge. These might include slight personality shifts, irritability, or difficulty with tasks that require planning and organization. For example, a person who was once very organized might start neglecting responsibilities or show uncharacteristically poor judgment. Friends and family might notice that something is off or different, but the changes are often attributed to stress or aging rather than a serious underlying condition. In stage 3, moderate behavior changes and apathy occur. During this stage, behavior changes become more pronounced. The individual may display inappropriate social behavior, lose interest in activities they once enjoyed, or exhibit impulsive actions. Apathy, or a lack of interest in anything, becomes more evident. This can be distressing for loved ones, as the person with FTD may appear to lose their sense of empathy, becoming more self-centered and less emotionally responsive. At this point, the disease can often be misdiagnosed as a psychiatric disorder or early onset Alzheimer's. In the next stage, the language problems start to surface more prominently. The person may struggle to find the right words, which is known as aphasia, use incorrect words, or have difficulty understanding language, which can all lead to frustration and social withdrawal. Communication becomes increasingly challenging, and the individual might instead begin relying on nonverbal cues or gestures. This stage is often when caregivers and medical professionals recognize the need for a more in-depth neurological evaluation. As FTD progresses, it can begin to impair motor functions due to the affected areas of the brain. Individuals may experience difficulty with movement, including problems with balance and coordination, or symptoms similar to those seen in Parkinson's disease, such as tremors or rigidity. This stage can lead to a decline in the person's ability to perform daily activities, putting more responsibility on caregivers. In the severe stage, the cognitive and physical abilities of the individual severely decline over a 1 to 2 year period. Some become completely dependent on others for their care, losing the ability to communicate effectively or perform basic tasks like eating, dressing, and bathing. Memory loss tends to become more significant during this period. This decline might look like not recognizing loved ones or becoming disoriented in familiar surroundings. The final stage of FTD is marked by profound physical and cognitive impairment. The individual may become bedridden and lose the ability to communicate entirely. Swallowing difficulties often develop, increasing the risk of aspiration pneumonia, which is the common cause of death in FTD patients. Palliative care tends to become the focus during this stage, aiming to ensure comfort and dignity in the final months or years of life. Vascular dementias include a number of disorders in which cerebrovascular disease prevents proper blood flow to the brain, depriving brain cells of oxygen and nutrients, which lead to cognitive decline. Damage to blood vessels can occur as a result of a major stroke, a series of tiny strokes, or chronic untreated high blood pressure. Because vascular dementias are numerous and complex, symptoms vary. If dementia is caused by a major stroke, the person may be confused, disoriented, and have trouble speaking or understanding others. If dementia is due to a series of small strokes, the symptoms may include impaired judgment, sudden bursts of laughter or tears, lack of focus, difficulty finding words, absent-mindedness, tremors, muscle weakness, and balance problems. As with Alzheimer's disease, people may have memory loss, but visual cues may jog their memory. The main goal with vascular dementia is to prevent further damage to the brain by reducing the risk of a future stroke. Stroke survivors are encouraged to quit smoking and drinking, and to manage their high blood pressure, cholesterol, and diabetes with medications and lifestyle changes. Vascular dementia may be mixed with other dementia types. Parkinson's disease is a movement disorder. The stages in Parkinson's disease are tracked differently than other diseases. The main tracking tool used by professionals measures where the disease symptoms impact the body, just on one side, in the middle, or on both sides, and then the severity of gait and the balance from there. As you can see from the two graphics on the screen, there is a lot more to Parkinson's disease than tremors and altered gait. Once the disease impacts the whole body, a person will need help with activities of daily living and may not be able to fully live independently. Parkinson's disease dementia is a decline in thinking and reasoning skills that develops in some people living with Parkinson's. The brain changes caused by Parkinson's disease begin in a region of the brain that plays a key role in movement, leading to early symptoms that include tremors and shakiness, muscle stiffness, a shuffling step, stooped posture, difficulty initiating movement, and lack of facial expression. As brain changes caused by Parkinson's gradually spreads, the person may also experience changes in mental functions, including memory and the ability to pay attention, make sound judgments, and plan the steps needed to complete a task. We have talked about dementia scales and stages, and one has to wonder, why does it matter? Why do we need scales and stages for dementia at all? It matters for science, for caregivers, and for programs and services for persons living with dementia and their loved ones to ensure quality of life for the duration of life. It matters for science. In November of 1901, Augusta D., a 51-year-old female, was admitted to the Frankfurt Asylum in Germany and was put under the care of Dr. Alois Alzheimer, a biology psychiatrist who was overworking himself to process the grief of losing his wife. Augusta D.'s husband noted that beginning in March, the symptoms of paranoia, progressive sleep and memory disturbances, aggression, and confusion were present. Her symptoms increased until she was unable to recognize her husband or her doctor. Dr. Alzheimer documented her case very precisely from the time of her admittance until her death on April 8, 1906. The significance of her case would not be recognized for decades. The science of Alzheimer's disease and other related dementias has come a long way since 1901. The electron microscope was invented in 1931, allowing us to do further study of the brain. Cognitive measurement scales were developed in 1968. Alzheimer's disease was recognized as the most common cause of dementia in 1976. The Alzheimer's Association was founded in 1980, and the first Alzheimer's drug was approved by the FDA in 1993. President Ronald Reagan was diagnosed with the disease in 1994, but interestingly enough, it wasn't until 1995 that Dr. Alzheimer's care notes for Augusta D. were found, fully confirming her as the first documented case of Alzheimer's. Many, many wonderful things have happened since 1995, and I encourage you to look at the milestones on the website linked on the slide. It matters for caregiving. We can take the stages of dementia and make a plan for how to prepare for each one. Early in the disease, it's important to ensure that the person with the disease's voice is primary. What do they want regarding care for the rest of their lives? Do they have someone appointed as a spokesperson for them? Do they have their legal affairs arranged to provide for them for the rest of their lives? Who do they want to see now instead of later when things progress? Where do they want to go? What's on their bucket list? And how can you assure that their safety is priority? If they cannot remain safely at home, what is their wishes? To live with another family member? To have family move in with them? To move to a facility? Avoiding the answers to those questions makes life harder for caregivers going forward. Scaling and staging the disease helps us to determine the best answers to questions from the very beginning. As caregiving really ramps up, what needs to be put into place so that you can take a break on a regular basis? What information do you need to know to understand what your loved one is going through? What skills do you need to develop to continue to provide care? Are you physically able to provide care? Where can your loved one go to remain engaged and active? Sitting in front of the TV is no better for an adult than it was for your kids when they were teenagers. What safety concerns may arise now that they need to be addressed? Wandering? Mistaking household items for food? Are there steps inside the house? What about driving? How do you communicate with someone who denies there's anything wrong with them and refuses to do what you ask them to do? How do you handle it if they see something that's not there or accuse you of taking something of theirs? Understanding that your loved one is in mid-stage dementia may help you answer these questions. In the severe or end stage, what services do you need to hire to ensure your loved one's wishes are met? What plans do you need to shore up to make sure you get sufficient breaks and respite? What are the long-term care options in your area? Understanding that your loved one is toward the end of their journey helps you to make plans for them, but also helps you be able to take care of yourself. Senior Services is a program and service provider in Forsyth County, North Carolina, with services that can help. Our core services include the Williams Adult Day Center, an award-winning adult day center that provides a safe, fun, and structured day program for persons living with dementia and frailty. Our nutrition services include our home-delivered meal program called Meals on Wheels and 4 senior lunch sites where older adults can participate in activities, games, programs, and share a meal with others 3 times a week. Our in-home services include home care, which helps with bathing and other ADL needs. Our Living at Home program is a Medicaid waiver program. Our Aging Resources team has over 80 collective years of experience and provides a helpline, caregiver education, and an employer benefit program called Elder Care Choices. Our Creative Connections program connects older adults with the arts. Research has shown that arts and creative-focused activities promote healthy aging. We utilize volunteers across all of our programs and would love to find a place for you. Senior Services' mission is to help older adults remain at home for as long as possible and to help them age with dignity. With concern for those who care for senior adults, we also help caregivers through services and education that will benefit them. Thank you for listening and viewing this presentation. Contact information, including a phone number and an email address, are on the screen. Please reach out if you need assistance or have questions. Have a great day.